السلام عليكم شباب.
وعليكم السلام ورحمة الله.
واضح الباوربوينت بلا زحمة؟
نعم دكتور.
تمام. احنا اليوم إن شاء الله we'll continue with our fifth lecture of pediatric cardiology or congenital heart disease in general in adult and pediatric population. And we reached today with cyanotic heart disease. In the previous lectures, we talked about the cyanotic congenital heart disease, including the most common cyanotic include VSD, ASD, PDA, provocation of the aorta. And today we will talk about the two most common cyanotic congenital heart disease, including tetralogy of Fallot and transposition of great arteries. There is many types of cyanotic congenital heart disease. As we know, most of them starting with T letter, as we said previously. Uh, so you cannot forget it, like tautology of Fallot, transposition of a great artery, tricuspid atresia, total anomalous pulmonary venous return. As you see, these congenital cyanotic heart disease all start with T letter, so you can remember it. The, the first one of them will be a tetralogy of Fallot, which is the most common type of cyanotic congenital heart disease, and usually accounts for about 10% of all congenital heart disease. It is one of the truncal family of heart lesion in which the primary defect is anterior deviation of the infundibulum septum. Uh, this is the muscular septum that separates the pulmonary and aortic outflow. As a consequence of this deviation, we will have four anomalies. ذلك هم لها دائما يسموه سامعيها فتحة رباعية، زين أو أربع فتحات. هي مو أربع فتحات بالحقيقة. هي عندنا الفيرست هو يكون obstruction to the right ventricular outflow. right ventricular outflow اللي هو before the pulmonary valve راح يكون عندنا obstruction بيه or stenosis. So this will result in usually the pulmonary artery, if its flow is small, so the artery will not be well developed and take its original size. So the size usually will be smaller than the normal, and as a result of this decreased size may have various degree of branches pulmonary artery stenosis. So the branch or at the end of the branches may have different part of stenosis. This will be all obvious in the cath lab, in the catheterization before the operation. We must do a cath for every patient with tetralogy of Fallot to see the anomalies associated with it and associated stenosis. So this is one of the uh, pictures we see it in the catheterization before surgery. Also, the second consequence of this deviation will be VSD, which is usually non-restrictive and large. Liver will be small VSD. And the third part will be the right ventricular hypertrophy, the right ventricle as a result of a severe stenosis. So the right ventricle will be stenosed. And lastly, we have dextro position of aorta, the aorta not in normal position, and there is overriding of ventricular septum. هاي البيكتشر بنشوف بيها الفور ديفكتس اللي حكينا عليها. الكورنر ستون in this uh, anomaly is the pulmonary stenosis. So we have pulmonary stenosis. This is the first number one, as we see, our right ventricular outflow obstruction. This will result in the right ventricular hypertrophy. Have a second as a result of severe stenosis. pump بتعرفون pump عندنا احنا ventricle عندنا stenosis of the valve. So this will with time will result in the hypertrophy as a result of increased pressure with severe obstruction. So the right ventricle will be hypertrophied with time, and the third part will be overriding overriding of aorta. Overriding meaning the aorta will usually, as we know, it is open into the left ventricle, while in tetralogy of Fallot, the aorta will open into both the ventricle, the LV and the RV. شوف البوزيشن مالته هنا شلون فاتح على two ventricle متحرك المكان dextral position of the aorta. لذلك صاير الاوبننج مالته على التو فالف، فهذا هو معناته الاوفررايدنج of the aorta. and as a result of this overriding طبعا راح يصير عندنا large non-restrictive VSD. ال VSD تشوفوه هو عبارة صاير يعني متنم بالضبط أكثر مما هو VSD، فلذلك البلد راح يروح ويجي براحته systolic and diastolic between the right and left ventricle. So the VSD will be very large in this case. طبعا الفورث احنا قلنا هو الفنتريكولار septal defect. طبعا there is another entity of the top. It's called complete causing complete obstruction of the right ventricular outflow. We call it top atresia, which is usually the same. Components of tetralogy, classical tetralogy of Fallot, but associated with athletic pulmonary valve. So the pulmonary valve will be closed. This is have a different presentation and a different treatment from the classical tetralogy of Fallot. Different time of management and surgery. The degree of pulmonary outflow varies with the severity of the obstruction, determining the degree of patient cyanosis in tetralogy of Fallot. This obvious, as we know. If the obstruction is more severe, the cyanosis will be earlier, and the patient will present earlier in life. While if the obstruction is less and mild or moderate, the presentation will be late, and the cyanosis will take time to present to the physician or to the pediatrician because of mild cyanosis or even acyanotic in the early life. This type, which is associated with mild obstruction, we call it the pink trough. Pink trough means acyanotic tetralogy of Fallot because of, as we said, the cyanosis will depend on the severity of the obstruction. What are the associated anomalies with the tetralogy of Fallot? Every disease will have associated anomaly. This includes the first part is congenital abscess of pulmonary valve. This is also sometimes the books refer it to another entity of tetralogy are followed, we call it curve absent pulmonary valve. So there is no pulmonary valve. The second associated anomaly may be associated with PDA, and the last third part will be right-sided aortic arch, which is present in about 20% of patients with tetralogy are followed. This picture we see in the gray, dark, and black cross. In the right side, this is the normal side for the aortic arch. Here we ascend from the femoral artery to the aorta, common iliac, and the aorta. This is the classical pathway for us. When we ascend and we see it from the right side, this is called the right-sided aortic arch. What about the clinical features of a patient with tetralogy of Fallot? First, as we said, these are the cyanotic congenital heart disease. So the first presentation will be the patient will present with cyanosis. But this cyanosis is usually, as we said earlier in this lecture, it is late onset cyanosis, and the patient will not present at birth, usually the first few days after delivery, not like the other cyanotic heart disease like TGA, the truncus arteriosus, tricuspid atresia, anomalous pulmonary venous return. These patients usually the cyanosis will present earlier and during the first few hours after the delivery, while in top, the presentation will take several weeks, and as we said, will depend on the severity of the right ventricular outflow obstruction. So may appear at the cyanosis appear at the end of the first 4 weeks of life, or take 1 to 2 months of life. Some infants less than 1 year of age who are presented with mild cyanosis may suddenly develop deep cyanosis and shortness of breath, and usually after waking up, this is called the hypercyanotic spells, or hypoxic spells, or theta spells. So they have usually in the early, in the just in the middle of the infancy, usually 3 months of age, with attacks of severe cyanosis and shortness of breath and irritability and excessive crying. These attacks, we call it the hypercyanotic spells or the hypoxic spells or the theta spells. What are the precipitating factors for these spells, including the feeding, aggravate the spells, excessive crying, also may aggravate it, the defecation, and strenuous exercise for the infant, and also iron deficiency anemia. As we said, the spells can be either short, lasting for a few seconds or minutes, or long, may end with loss of consciousness, take a few hours to days. I see the cases continue 2 3 days, and this will end with loss of consciousness, severe hypoxia, and convulsion, and may end to death. How we know it? Diagnose it, as we said, these attacks were associated with shortness of breath, severe cyanosis, and excessive crying of the patient, irritable, decreased feeding. So when we examine the patient, we put the stethoscope on the heart, on the chest, and we see the disappearance or decrease of the systolic murmur of the pulmonary stenosis when because of severe stenosis and these spells, so the murmur will disappear. There is no flow across the pulmonary valve, and we think usually we think of BC spells, and we give the patient the proper management. We'll talk about the management of the spells later on with the treatment of tetralogy of Farad. Now we will continue with the presentation of TOF, including the second, as we say with cyanosis. The second presentation clinical features is finger clapping, and this usually occur due to chronic hypoxia, and also it is also not present in early a few months of life, and usually it takes a few months to about at least 6 months of age to appear. So you should not look for finger clapping in the first few months of life. Also, the third clinical feature, a patient, as we say, all of the patients with the cyanotic congenital heart disease, they will have failure to thrive and growth and developmental retardation due to chronic hypoxia. And the third part is clinical feature is the squatting position. Behind picture, they show how squatting. The child shows the squatting position. This to uh, as a result of exercise intolerance. So they bend their knee to the abdomen to increase the systemic vascular resistance and decrease the venous return and decrease the hypoxia. So they take this position. This is typical for cyanotic congenital heart disease to increase the systemic venous return. What are the examination? On examination, what we will see? We will see the single second heart sound, and usually due to severe stenosis, and usually we hear a systolic murmur due to pulmonary stenosis. This is usually we hear it in the second or third left intercostal space, the position of the pulmonary valve. And as we said earlier, this murmur intensity will disappear during vespers. Usually, we don't hear. This is a common mistake when I ask the students what are the murmurs. We hear it in the patient with TOF. Always they remember the VSD and say there is a pansystolic or holosystolic as the new uh, name for the holosystolic murmur, continuous murmur from the first to second heart sound. Previously, we called it the pansystolic. Now the new name is holo, the same. So the the patient with tetralogy of Fallot, they don't have a systolic murmur because of VSD. As we said previously, why? Because the VSD is very large and non-restrictive, so uh, we don't hear a murmur. The murmur need a shunt will need a small tunnel and difference in pressure between the right and left ventricle. In case of tetralogy of Fallot, as we said, because of the overriding of the aorta, the VSD will be very large, and the pressure between the right and left ventricle will be equal. When we enter the cath lab and do cath for the patient, we measure the pressure in the right ventricle and measure the pressure in the left ventricle. They should be equal in in uh, in measurement because of non-restrictive VSD. So we don't. This will not produce a pan-systolic murmur. The systolic murmur is just ejection systolic murmur due to pulmonary stenosis. What are the investigations that we should do for the uh, patient with TOF, including chest X-ray, and usually this classical shape. Usually we see it. We remember it. One of the uh, pictures that we keep us suspicious of pathology of heart is the boot shape heart. This you see the picture on the right side. How the heart take the shape of the boot because of the right ventricular hypertrophy and the change position of the aorta. So there is a straight border of the upper part of the mediastinum, including the heart, and there is the right ventricular hypertrophy. So making the heart taking the boot shape. And the second uh, thing we see it is the origamic lung because of severe pulmonary stenosis or right ventricular arterial obstruction. So there is origemia of the lung, as we see. It is the picture of the lung will be more dark than the normal. This and 20%, as we say, of a patient will have a sided aortic arch. There will be the arch will appear on the right side, not on the left side. This is the knob of it, like the normal population. What about the ECG? We see the right ventricular hypertrophy and right axis deviation, and the third part, the definitive diagnosis will be done by the echocardiography. We do echo for the heart, and usually we see obviously the right ventricular hypertrophy. We see the pulmonary stenosis and overriding of the aorta, and also we see a very large non-restricted VSD. What are the complications associated with patients with pathology of thyroid, including cerebral thrombosis due to chronic hypoxia? These patients with cyanotic congenital heart disease are liable for polycythemia, and this will increase the blood viscosity leading to cerebral thrombosis. So they are liable for CVA usually below 2 years of age. Brain abscess also may occur in children usually older than 2 years of age. Infective endocarditis and a rare complication, and usually we see it uh, in the extreme form of TOF, and usually with the pink type with the mild obstruction of the RVOT. So we see patient with heart failure. Usually heart failure is rare in patients with TOF because of the protection of the lung and heart by pulmonary stenosis. But when we have mild pulmonary stenosis, this large VSD will act like the usual classical VSD, and this large shunt will end with heart failure. So we see it usually either every month of life because of mild pulmonary stenosis or if there is a large collateral circulation. What about the treatment of patients with tetralogy of Fallot? We include the medical therapy first for the spells, state spells or hypoxic spells, including the position of the patient in the knee chest position. As we say, this is the squatting position, so the knee will bend near the abdomen of the patient, and this will increase the systemic vascular resistance, so decreasing the shunt. decreasing right to the left shunt and decreasing the cyanosis. Also, we give O2 for the patient. Hydration is important part of the treatment of patient with pathology of fallot, and sedation, as we say, irritability, excessive crying. This will increase the shunt and decrease the systemic vascular resistance, and this will increase the heart rate. So we give you the patient sedation with morphine. And fifth is beta blocker, propranolol, and to decreasing the stenosis, and sodium bicarb 1 to 2 cc per kg or 2 cc to 4 cc ممكن انه to correct according to the result of blood gas analysis correct the metabolic acidosis. This picture will see the diagram. We see how the patient treated with the theta spells. This is we see the knee chest position of the infant, and this is another position for the mother putting the infant. How see the hugging the baby and put him to decrease the irritability and decrease crying, and the legs how put to the knee to the near the abdomen, and usually the patient know when the infant develop attack and severe cyanosis. Usually they put him in this position to decrease the shunt. As we see the diagram, this pain or anxiety will increase the catecholamine state, and this will decrease the systemic vascular resistance and increase the peripheral vascular resistance with tachycardia. This will increase the shunt, right to left shunt, and decrease the right preload. This also will increase the cyanosis, and increasing cyanosis will increase the pain or anxiety. So this is this vicious circle will enter the child in it. So we must cut it by the medication, or even sometimes if we fail by medication, we do uh, cath for the patient or surgery for the patient to cut this vicious circle. So we increase the systemic vascular resistance as we see by knee chest position, by phenylephrine, decrease the anxiety by hugging the patient, and the treatment of acidosis, as we said, by sodium bicarb, and giving him beta blocker. If this all of them failed, we should do intubation and sedation of the patient and give him ketamine to increase the systemic vascular resistance. Sometimes even the intubation and will fail, and we do enter the patient into cath lab and do dilatation of the right ventricular outflow by putting a stent in the right ventricular outflow to relieve. This is a palliative procedure to relieve the shunt, to relieve the cyanosis temporarily until we do the corrective surgery, total correction for the patient at appropriate age for him, or the patient age allow for doing the total correction. Our knee position, as we see it here, so we should every mother with patient with TOF learn how to put the patient when develop the theta spells. Uh, Other part of the treatment includes the surgical part. This done by cardiovascular surgeon, and including two procedures. First, we call it the palliative procedure, and the second is total correction. The total correction needs good size of the heart and good uh, development of arteries and appropriate age. Also, usually this will be appropriate above 1 to 2 years of age. Um, Outside, they reach the 6 month of age for correction, but in our country till now, they need about 2 years or 15 kg of a patient. So 15 kg will not be uh, will not get it until the patient age about 3 to 4 years of age. So this is the total correction. What about the palliative procedure we can do? We call it the BT shunt or parallel torsing shunt. And this shunt usually it is, as we said, it is palliative, not corrective, and we do it for the patient with recurrent attack of spells and severe stenosis, and to cut this circle of recurrent attack of spells, we do a shunt, as we see it here in the picture, between the right subclavian artery and pulmonary artery to increase the blood flow to the lung and to overcome the severe right ventricular outflow and to decrease the cyanosis of the patient. A picture of the top, we see the four parts as we see it before previously. Uh, Now, the second part of our lecture, we'll talk about the transposition, detransposition of a great artery, the second most common type of cyanotic congenital heart disease, which is more common in males. This or two types ago. Today, both of them are more common in males than females, and usually divided into two types. It is usually either isolated, uh, we call it uncomplicated, or just a DTGA, or complicated, associated with other congenital heart disease like VSD. What are the problems with these patients with DTGA? D means dextro position of great artery, dextro transposition of great artery, and in this patient, usually the aorta will be arise from the right ventricle, while the pulmonary artery will arise from the LV. This is the picture which shows the normal heart. As we know, all of us, the aorta, the aorta will be arise usually normally from the left ventricle, while the pulmonary artery will arise from the right ventricle. In deposition of a great artery in DTGA, the opposite will occur. The, the pulmonary artery will arise from the left ventricle, while the aorta will arise from the right ventricle. So the deoxygenated blood will go to the systemic circulation, while the oxygenated blood uh, will will return to the lung. This is patient will be incompatible of life if there is no other associated shunt between the left and right side. So the shunt may be there is a PDA, so the patient will be PDA dependent in this case, will on the shunt of a PDA to continue his life, or VSD or ASD. So the part of the oxygenated blood will cross from the right side to the left side, and the patient continue his life. What about the clinical features of patients with DTGA? These are usually early onset cyanosis. On the opposite of TOF, as we said, they are those patients with TOF usually presentation will be late. Those Patient with DTGA representation is earlier, as we see in the first few hours of life. The patient will have severe cyanosis. The saturation will be 50, 40, 30 according to the shunt, if there is any shunt, and the size of the shunt uh, will depend, or the oxygenation will depend on it. And usually, will patient will not responding to oxygen therapy, and the patient develop also tachypnea, but it will be tachypnic, and of severe congestive heart failure may end with congestive heart failure because of heart failure, because of uh, no oxygenation. This heart will end with heart failure and severe pulmonary hypertension if the patient does, does not develop corrected early in life, usually first few months of life or in the infancy. If not treated, the patient will end with pulmonary hypertension and Eisenmenger syndrome. Death usually will occur if the patient not treated by a shunt, which is usually peritoneal procedure. So when we refer it for, we see the patient, examine it, and see tachypnic, cyanosis, and not responding to O2. The pediatrician, they think of cyanotic congenital heart disease, put mind, and usually, as we said, this presentation is early in life, so they refer it in the early few hours after delivery. They call us for echo study to do echo study for the patient, and the echo we reach the final diagnosis. We see the pulmonary artery arising from the left ventricle and the aorta arising from the right ventricle. So we do a palliative procedure. We call it Rashkin procedure. Maybe normal if there is no shunt and or small shunt, and but there is a single second heart sound. Chest X-ray is also important. We usually, if you suspect any patient with congenital heart disease, we do chest X-ray, as we say previously, one important investigation and available 24 hours for the physician or internist. And usually the clinical picture is egg-shaped. We see it on the right side. We see looks like the egg. This is uh, give us a suspicion of patient with DTGA. Why did mediastinum? Because of uh, change of a position of the aorta and pulmonary, and usually increasing blood flow, pulmonary blood flow, increasing pulmonary vascularity. On the opposite, with patient with tetralogy followed, we say previously they will develop oligemic lung. ECG may be normal or maybe right ventricular hypertrophy, and the echocardiography will be the definitive diagnosis. About the treatment? We should infuse, as we say, if you know the diagnosis of you have a strong suspicion of patient with cyanotic congenital heart disease, you should keep the patient on prostaglandin until you have the definitive diagnosis by echocardiography. Usually the echo not available 24 hours inside the hospital, so you should arrange for appointment for it. And if you suspect cyanotic congenital heart disease and the patient life depending on the duct, so you should give him a prostaglandin to keep the duct open, because at any time this duct will be closed and the patient will die on the table. So as we said in the previous lecture, to maintain the patency of the ductus arteriosus, we give the patient prostaglandin. The second treatment, اللي هي palliative treatment, as we say, the patient have a small PDA or patient life depending on PDA, and this will be closed at any time. So we do emergency cuff for the patient. We admit the patient into cath lab and do a Washkin operation. This Washkin, we enter from the right atria to the left atria, and we have a balloon with the cuff, and this balloon we will make a tear in the atrial septum. So, and we do a strong pull many times through the balloon, through the atrial septum, to make a tear on making an artificial atrial septal defect, so increasing the shunt between the left side and the right side. This will increase the oxygenated blood, and this is one of the palliative procedure. We immediately see the good results in the cath lab. We see the increasing saturation from 30, 40 to 70, 80s sometimes because of increase the shunt. The patient will be more comfortable immediately, decreasing the cyanosis until we do the definitive procedure corrective, which is we call it the arterial switch operation. Usually we turn the pulmonary artery to the right ventricle while the aorta to, to the left ventricle. There is another type of TGA, we call it the L12 TGA. This is different from the DTGA, or don't have many times, just 2 minutes about it to talk about it. It is called corrected type of transposition of a great artery, and this is usually rare type of congenital heart disease, and it is not cyanotic and present late on life. And they have different presentation from the transposition of great arteries, and the main anomaly associated with it here will be the change not in the great arteries, opening of the great arteries, but here the change will be in the ventricles. So the right ventricle will be on the left side, and the aorta will arise from it, while the left ventricle will be on the right side. So there will be ventricular inversion, change in position of the ventricle, and there is many anomalies associated with it. There is associated with arrhythmias, and later on, presentation of them, as we said, is associated with may discover accidentally in early childhood. If there is any associated anomaly like VSD with it, or later on the presentation may present with heart failure because uh, the right ventricle will not cannot compensate for the high systemic pressure for long time, will end with the heart failure uh, because different composition and as we said, the right ventricle will not tolerate the high pressure of systemic circulation. Need طبعا surgery, and different type of surgery will not enter with details. Need more time for it. This is the end of our lecture today, and we will have next week the last lecture. We're talking short notes about the heart failure. إذا أكو حد عنده سؤال قبل ما ننهي المحاضرة.
دكتور، إذا المريض ما مسوي إيكو فأنا ما راح أقدر أعرفه مثلا هو transposition of great arteries وهو depth dependent حتى
إيه.
نطيل بروستاجلاندين. فأنا شلون راح أشك بهاي الحالة أنه هو تي جي اي ودكت ديبندنت حتى أنا أنطي البروستاجلاندين؟
الطيب بروستاجلاندين وعلى مسؤوليتي، ما راح يضره اذا ما راح يفيده. ماشي، حتى اذا شكيت ممكن باذر ديزيز ما راح خليت البي دي اي اوبن، غير شنو المشكله؟ خليها اوبن، ممكن يومين 3 ايام زياده، احسن مما انه البي دي اي will be closed والبيشنت داي. انت بالبصره بالشطره، شوف وين مكان بعيد نائي وما عندك ايكو كارديوغرافي. اكو محاضرات هوايه ما موجود بها بيدياتريك كارديولوجي او كونجنتال هارت ديزيز. فهذا اذا تدزه تنتظر يومين وحضرت اجوال منها 3 ايام، هذا راح البيشنت يروح ينتهي ويموت اي لحظه، ممكن تنسد البي دي اي وداي. فانت خلي البي دي اي اوبن، شنو الخسران من عنده؟ خليه على بروستاجلاندين، واحنا اذا وصلنا للديفينيتيف دايجنوستس شفناه توف وما يحتاج البي دي اي راح نوقفه. زين، بس اذا هو طلع تي جي اي وانت خليته عليه، انقذت حياته بهالحاله هذه. واضح؟ فانت حتى اذا ما تعرف الدايجنوستس ماكو اشكال، خليه على بروستاجلاندين لحد ما نوصل definitive diagnosis by echocardiography. واضح عبد الله؟
نعم دكتور واضح.
اكو سؤال بعد شباب؟ تمام، اذا ماكو سؤال نلتقي ان شاء الله الاسبوع القادم و last lecture heart failure. good luck، موفقين.